Hey, future doctors, welcome to Vesserverse, where we dissect medical jargon into simpler topics. Today, our discussion is about sepsis, and sepsis is a really important topic that you have to be well familiar of. So let's start with the definition. What is sepsis? Your doctors will always ask you about sepsis, and the definition of sepsis is the first thing they would ask about. So, sepsis is a life-threatening organ dysfunction due to host-regulated response to an infection. Now, when do we tell this patient actually has sepsis? We have specific criteria. We say that there is a suspected infection, it is not necessarily documented. So we have a suspected infection, that's one, plus more than two SOFA scores, and we will talk about the SOFA score shortly. Now, you have to keep in mind that in the past, according to the old criteria, they used to say that there is an infection that is a documented infection plus two or more SIRS criteria. Now, let's talk about SOFA and SIRS. A SOFA score is a score that is composed of 6 parameters. 1, respiration. 2, coagulation. Then we have the liver, the cardiovascular, the CNS, and the renal system. So if we have damage in any of these organs, we grade that according to 0, which is normal, 1, 2, up to 4, and we're going to calculate based on that. Now, with this score, as you can see, we can, and it's scored out of 24, but we need only as low as 2 to say that this is a criteria for sepsis. So, for instance, just don't be overwhelmed. It seems like an overwhelming score, but the thing is that you have coagulation. And we will talk about this in the pathophysiology. This is one of the most important things that you have to keep in mind. So, in coagulation, typically you have it more than 150K. But if it drops, let's say, in a patient, you measure it in a patient and it's less than 150K, then this counts for 1 point. Or let's make it +1. And the next one, let's say you measured the Glasgow Coma score. You're looking at the Glasgow Coma score of the patient, and it's 10 to 12. This accounts for, as you can see here, 2 points. So you calculate everything, and you say that this patient has a 3 score, a 3 SOFA score, plus an infection or a suspected infection. We can tell that this patient has sepsis according to the new criteria. Now, if we look at the past criteria, we had SIRS. And SIRS stands for Systemic Inflammatory Response Syndrome. And the parameters are much simpler than that of SOFA. It's tachycardia with a heart rate more than 90, tachypnea with a respiratory rate more than 20, temperature, it could be hyperthermia or hypothermia, leukocytosis, and leukopenia. Or leukopenia. So, sometimes this sepsis, if it's not treated, if it's very severe, it can develop into a septic shock. So what do we mean by a septic shock? It is sepsis plus MAP and serum lactate. MAP is less than 65 millimeters mercury, and MAP stands for mean arterial pressure. That is, it's equal to cardiac output multiplied by systemic vascular resistance. Now we will talk about the pathophysiology, but what you have to keep in mind is that systemic vascular resistance is going to drop. And because it drops, we have MAP also drops. Serum lactate, again, we have serum lactate more than 2 millimoles per liter despite fluid resuscitation. So again, sepsis and MAP, serum lactate despite fluid resuscitation. Next, let's talk about the pathophysiology. All right, next, my friends, we're going to talk about pathophysiology. So again, we said that everything starts with an infection. Everything starts with a pathogen. And this pathogen will induce the innate immune cells, and the innate immune cells go crazy. And because they go crazy, we have a cytokine storm. These cytokine storms lead to two things: a systemic inflammation plus a coagulation dysfunction. These will lead to endothelial damage and microvascular thrombosis. And eventually, we have organ hypoxia and dysfunction. So let's zoom in and see what's really happening. So here we have a microvessel, a capillary. And what is happening is we have a lot of systemic inflammation, as we've said. So this systemic inflammation, you can imagine that it damages the endothelium. So it goes all the way here and it damages the endothelium. And when this happens, you remember from the coagulation cascade, sorry, actually the platelet activation lecture. So what we have here is that the tissue factor is going to be exposed, and that is going to lead to coagulation. So we form a microthrombus here, and this microthrombus is, as you can see, it's blocking the blood flow. So imagine here you have an organ, and you're blocking the blood flow to an organ. Now, what's going to happen here, apparently, is that they have hypoxia. And because of hypoxia, they're going to turn from aerobic into anaerobic. And therefore, we have lactate, apparently. So again, and what is, oh, we forgot DIC. So what is DIC? DIC is disseminated intravascular coagulation. And this is really bad because intravascular coagulation. Okay, this is a really bad condition because at one hand, you form a lot of thrombus. And when you form this huge amount of thrombus, you're consuming all of your platelets. And if you're consuming the platelets, then you will have no platelets left for coagulation cascade. And therefore, you have bleeding. So you have both clots plus bleeding. And the bleeding is typically going to occur as nosebleeds, for instance. So just keep that in mind. So for the etiologies, the most common cause is pneumonia. And we have many, many other causes like urinary tract infections, abdominal infections, whether it's post-op or host-related. Let's say we have spontaneous bacterial infection due to gut translocation, or it could be viral, sometimes due to influenza or even COVID-19, bad old days. Next, it's going to be fungal. Sometimes, most commonly, it's Candida, but sometimes it could be caused by Aspergillus. We have culture negative, and this is the worst situation that we can have here as an etiology. Because the cause of the sepsis is unknown, it is an infection, but we can detect this infection. And this is going to lead to us using empiric treatment. So we're going to give empiric antibiotics, and we're not able to narrow it down because we don't know what is the underlying infection is. So it's typically because of an occult abscess or sometimes endocarditis. So who is vulnerable to sepsis? What are the risk factors of sepsis? So we can divide this into either host-regulated or medical triggers. For host-regulated, it could be an old age. We have a geriatric, or it could be diabetes mellitus. Sometimes it could be chronic diseases like COPD, which is chronic obstructive pulmonary disease. It could be due to immunocompromisation. We have an immunocompromised patients. Maybe they have an HIV infection. We can also have drug abuse. Typically, here we're talking about IV drug abuse, alcoholism, or even smoking. Sometimes it could be medical triggers like a recent surgery, so a post-op patient, or an indwelling catheter. It could be a Foley catheter, a urinary tract, or an IV line. So next, let's discuss clinical presentation. For clinical presentations, the patient can present with fever, but you have to keep in mind that some patients will develop hypothermia. So we have fever or hypothermia. We have hypotension. Again, we said that the MAP is going to be decreasing because we have a decrease in systemic vascular resistance. We have altered mental status with a Glasgow Coma score less than 15, in which you are alert and cooperative. the patient will develop oliguria. And again, we have, as we discussed earlier, we have organ dysfunction, and therefore we have oliguria, especially we have acute kidney injury or hyperlactatemia, again, an increase in lactate. And that's because we can't meet the demand of oxygen. If we have that, we turn from aerobic into anaerobic. For the diagnosis, there is no specific test that we can use and that we can just test for and we say that this patient has sepsis. So instead, we do a CBC, we measure lactate, we take cultures, one blood culture and urine culture. So we have to take it from the blood and the urine and scores. We look at the SOFA score, as we have said. And then lastly, once we diagnose the patient, we have high lactate, we have an infection upon doing a CBC, upon doing a culture, and we have a score, a SOFA score more than 2. At this stage, we can say that this patient officially has sepsis. What can we do next? Treat them, my friends. So, for treatment, we have 3 important steps. One is an immediate resuscitation. And this immediate resuscitation is going to be done within the golden hour. So any emergency has a golden hour. And a golden hour of sepsis and a septic shock. In this situation, it's a septic shock that we need to resuscitate. So when we're resuscitating here, we give crystalloids, broad spectrum antibiotics, and we narrow it down as we get the results of the cultures. Now, typically, for the broad spectrum antibiotics, we give peptaz, which is piperacillin tazobactam, and vancomycin. This is going to make sure that we're covering gram-negative bacteria. And one of the most important gram-negative bacteria that we have to cover is Pseudomonas. Next, we have vancomycin, and that covers gram-negative bacteria. And because it's vancomycin, what we have to think of is MRSA, methicillin-resistant Staphylococcus aureus. And if you need a video about this topic, about antibiotics and an antibiotics ladder in which we have to step up and step down, let me know in the comments below. Next, we have vasopressors. The second thing that we do in the treatment, we resuscitate, and then we give vasopressors. So for vasopressors, the first line is going to be norepinephrine. I'm not sure if this should have been vasopressors, but the thing is that we don't start really with vasopressors. We start with norepinephrine. If we have constantly low blood pressure, low systemic vascular resistance, then we go with vasopressor or epinephrine. But an important thing to remember is that we never give vasopressors alone. We give it with norepinephrine. We start norepinephrine. It's still we have refractory blood pressure low, so hypotension, refractory hypotension. Then we give norepinephrine plus vasopressors. If it's still refractory, we can go with epinephrine. You would want to never use dopamine unless you want the patient to develop arrhythmias. Therefore, we don't want the patients to develop arrhythmias and then we avoid it. And then lastly, we have suppurative treatment. If the patient has acute respiratory distress syndrome, then we go with ventilation. We want to control blood glucose, but it's not very tight. Typically, the target it's between 140 to 180, and then hydrocortisone. Because it's a stressful situation, we need to give steroids so we can cope with this stressful situation. That's it, my friends, for sepsis and septic shock. If you like the video, give it a thumbs up and subscribe to the channel